Well, it's a pleasure to be here with you today, and I appreciate everyone who's signed on. We're going to be focusing today on a little bit of a niche topic in the realm of immune-related adverse events, and I'm really excited to talk about it because it's something that I don't think many people are aware of. It's something that you may not have much experience with personally. So I think my goal for you today is hopefully to bring something new to you that maybe you haven't really heard about before or you haven't had much experience with, and bring awareness to you and help you know what to do if you see a case like this come up to help get the patient their best care. NCCN has a map here of member institutions, one of which I'm part of in Utah, Huntsman Cancer Institute at the University of Utah. We are an alliance of leading cancer centers that are devoted to patient care, research, and education, and our mission is to improve and facilitate quality, effective, equitable, and accessible cancer care so all patients can live better lives. And our vision is to define and advance high-quality, high-value, patient-centered cancer care globally. And during my time on the panel for the management of immunotherapy-related toxicities, I've just had a pleasure working with experts across the United States and bringing the best experience and expertise to the guidelines so that you can benefit from them. And so I hope to share some of that with you today. The learning objectives I have for you are to be able to identify the potential for immune checkpoint inhibitor or ICI therapy to cause uncommon immune-related adverse events or IRAEs, including oral toxicities, which require the prompt management of patients with cancer. Recognize the types and grading of oral IRAEs, which may affect the mucosal tissue and the salivary glands, and to develop proactive strategies for the supportive care, management, and monitoring of patients with oral IRAEs. I have some abbreviations listed for you here today. We're going to be using several of them multiple times, so I have them listed if you need to go back and reference them. Let's start with a patient case. I'd like you to think about this case and what would go through your mind if you heard about this case, kind of going in blind, if you will. But if you would imagine SL as a 68-year-old female with metastatic melanoma, which is my clinic of interest, and so both of our cases will be patients with melanoma today. Since the start of the COVID-19 pandemic, she's continued to insist on keeping a mask on during all appointments and not removing it. She has new progression of disease, and you are the oncology clinical pharmacist. You're intended to go to educate her on her next line of therapy, which is encorafenib and binimetinib, which are targeted therapies. She mentions her dentist recently said to her that she had significant tooth decay and gingivitis, and she may need to have some or all of her teeth removed. You ask her to remove her mask, and you see that evidence of severe dry mouth and extensive dental caries exists. She says the dry mouth started about 3 to 4 months ago while she's on pembrolizumab, but she just didn't say anything about it, as she assumed it did not, the cause was not due to immunotherapy. Which IRAE should we be most concerned about for SL, and what would the most appropriate interventions be for her? I want you to keep that in mind as we go through this first section. And I will say going into this that I assume somewhat of a baseline understanding of immunotherapy. We're going to be reviewing a few aspects of immune checkpoint inhibition and what immune-related adverse events are, but I kind of assume that you have some general going understanding of that coming into this, because we are going to be going a little bit into the weeds with oral toxicities here today, but we will review some basics. Immune checkpoint inhibitors cause benefit for cancer by inhibiting immune checkpoints, which results in T cell overactivation, allowing the immune system to identify cancer that is often highly mutated, has a high burden of somatic mutations, and triggers that immune activation that we need to seek and destroy cancer. There are now 13 different FDA-approved ICI agents. It's hard even to keep track of them. There are so many, and I've listed the new ones here for you. I've highlighted them and subdivided them by class, and you can see the list here. But they've driven in the past decade a significant overall survival benefit in human cancer, with over 90 FDA-approved indications, which becomes harder to track each year. But this is, I believe, accurate as of this month. And now over 1 in 3 patients with cancer are eligible for immune checkpoint inhibitors. And this study that I referenced with this is now 4 years old, so I imagine that this statistic is possibly even higher. However, immune checkpoint inhibitors do have a subclass of toxicity that trigger, because of the same mechanism for which we get cancer benefit, these also can trigger attack of self-antigen, and we call these IRAEs. And they imitate autoimmune diseases. They do not match them, but they imitate them. And they've been a huge source of new admissions and management in patients because of the increasing use of them. We have lots and lots of patients being treated for IRAEs now. So that's why it's so vital that we become aware and understand the breadth of toxicity that can happen with these. This is a list of some immune-related adverse events that can happen, most of which are dealt with in the NCCN guidelines, for which I'm a panelist. I have highlighted here a few that we're going to focus on today that were just recently added to the guidelines. And the real main point with immune-related adverse events is just to understand that when we are using immune checkpoint inhibition, we are kind of indiscriminately activating the immune system, those T cells, and sometimes it results in friendly fire. So any organ can be inflamed by the immune system. And that does include the salivary glands and oral mucosa, which are often overlooked and are a class of immune toxicity that is becoming better recognized. Oral toxicities from ICI therapy are really inconsistently reported in clinical trials. And so it's very difficult to understand what the real incidence of these are. There are a few studies that we can use to get at the incidence, and I think that we can draw some conclusions, one of which was actually done this year. It was a meta-analysis, but there was an observational cohort study that was done in 2021 that was published of an observational cohort of 4,683 patients that received immune checkpoint inhibition, I believe in Boston at Mass Gen and the associated hospitals there, from 2011 to 2019. And what they found was that there was an overall incidence from their analysis of 6.8% of oral toxicities from ICI therapy noted. The most common being dry mouth or xerostomia at 4.6%, followed by oral mucosal diseases or disorders at 2.3%, followed by taste changes or alterations with dysgeusia at 1.6%. So this was, I think, a really interesting study that was done, and one of the first kind of peeks at what maybe the real incidence is of oral toxicities from ICI therapy. There was since done a meta-analysis earlier this year and published that demonstrated outcomes from 95 different clinical trials that were compiled and analyzed that way. And you can see the outlay here of different oral toxicities that are subdivided a little bit more so than the observational cohort study that was published earlier a few years back. But what they found was that a rate of 5% for dry mouth with a 95% confidence interval of 4 to 6%, 3% for mucositis, 3% for dysgeusia, and 2% for dysphagia, and so on. And you'll note here also oral pain listed with 3%. There are some of these that we're not going to be dealing with today. And there's a little bit of, I think, still growth to be had in this field with us understanding maybe what is actually caused by ICI therapy, what maybe there is overlap with. And so keep that in mind as we discuss these, that this is kind of our best shot right now at trying to understand and describe what we currently know from oral toxicities and how to manage them. But these were a focus with the version 1 in 2023 with the NCCN guidelines for management of immune checkpoint inhibitor-related toxicities. We spent a considerable amount of time in a subcommittee working on these to get them added. I had some personal experience, which I'm sharing with you today, with these toxicities, and so I was very passionate about getting these added, and so we were able to make that happen. But this clearly is a field that's still evolving, and we're not entirely sure on the best management. I think that that's kind of the case with most immune-related adverse events. So first off, we're going to discuss dry mouth or Sicca syndrome, which is what we believe to be the most common oral toxicity experienced during ICI therapy. And so what are we meaning, or what are we talking about when we talk about Sicca syndrome? I think, it's funny with immune-related adverse event management. I'm sure that a lot of the people on this call probably feel like you're often, putting a cap on every now and then with, completely different specialty than what you ever expected to kind of deal with in your practice with cancer care. And that's exactly it. We're dealing right now with a rheumatologic disorder. And so this is something that maybe you haven't thought of before. Sicca syndrome is something that is very similar to Sjogren's syndrome. So if you think back to pharmacy school, nursing school, medical school, talking about Sjogren's syndrome, what is that? What's the presentation of that? Usually it's dry mouth and dry eyes. This was first reported in the context of immune checkpoint inhibition with 4 patients that were treated with nivolumab plus ipilimumab in 2017. So just to put that in context, we had our first PD-1 inhibitors approved in the 2014, 2015 time frame. And so this was several years before we really kind of were realizing what was happening, or starting to realize what was happening with immune checkpoint inhibition and oral toxicity with Zika syndrome. So I think that's important to put in context when you see the results from this early pharmacovigilance study that reported a 0.3% incidence, which seems very low and probably is an under representation of what the actual incidence is. There were also very few initially clinical trials that even reported about dry mouth or anything akin to that. And in those studies, there was anywhere from 3 to 24% incidence reported. So I think we're getting at now the real true incidence of Zika syndrome sitting at about 5%, which makes it one of the more common immune-related adverse events that we see. So I think keep that in mind, that I don't think that it's fair to say this is necessarily a rare syndrome, but it is something that has been underappreciated. There are some distinct characteristics that differ and set Zika syndrome apart from Sjogren's syndrome. So we are not, I think it's important to point out that we are not causing Sjogren's syndrome with immune checkpoint inhibition, because that is an incurable disorder that is autoimmune and significantly affects quality of life long-term, chronically, for patients that suffer from that. Now, Zika syndrome does have similarities to Sjogren's syndrome, and in some ways, it can significantly affect quality of life long-term. But the big differences, I think, number one would be that Zika syndrome is generally very abrupt in onset after immune checkpoint inhibition, and usually within the first 3 months of treatment. That's the first thing. It does significantly affect quality of life, but usually dry eyes is not something that we see with Zika syndrome, and so it's primarily dry mouth that we're dealing with. Now, have I had a patient with dry eyes along with dry mouth? Yes, I have, but it's not the majority, and it's not usually what we see. Something also interesting that we don't see with Zika syndrome are any of the traditional blood tests that we usually use for diagnosing Sjogren's syndrome. And these are antibody tests that you see listed here with ANA, anti-SSA, and anti-SSB. Those are usually what would point to a diagnosis of Sjogren's syndrome, and we do not see positivity here with Zika syndrome. And finally, one of the biggest things, I think, is that Sjogren's syndrome is traditionally a B-cell mediated type of autoimmune disorder, whereas Zika syndrome is primarily driven and mediated by T-cell driven glandular injury and inflammation. And finally, sialadenitis. So this is inflammation of the salivary glands. And this is something that we see more commonly in Zika syndrome. And I think it's important to look at this image on the bottom here, where you see staining that indicates more T cell presence in the salivary glands and not B cells. So there's CD20 negativity. And so there's no B cells in those glands that have been stained. Zika syndrome, I think, can be best described in 3 different case series. And so we're going to kind of highlight some aspects of these 3 different case series. These are the largest case series that we have for Zika syndrome that I'm going to go through. Really, the main one, and this is what kind of started it all, was Warner and colleagues in 2019. And this was a case series of only 20 patients. They had the immune checkpoint inhibition treatment you'll see listed here, but primarily PD-1 and PD-L1 treatment. 4 of the patients, so 1 in 5, were noted to have pre-existing autoimmune disease. Keep that in mind. But all of them had severe dry mouth that affected their eating and sleeping. They had very low saliva flow. They had new dry eye symptoms in a minority, so 6 out of the 20, not quite half, but definitely significant number that still had dry eye symptoms, even though it's less common. The normal interval kind of fits within that 3-month time frame that I just talked about. Again, the markers, the antibodies, are not positive in most patients. And we had inflammation of those salivary glands in the majority of patients, mild to severe, that was noted. As well, and as far as management, ICI was held for 12 patients, and steroids were started in 10 patients. And so this is something where the management is going to be variable between these different case series. I want you to really take note of that. But in these patients that were for which about half had treatment held and steroids initiated, there was subjective improvement in the majority of patients, but salivary secretion did not significantly improve. And so there was some long-term ramifications of this. And so, what are the main key takeaways from this? Fast onset, with or without dry eyes, but usually and almost always with severe dry mouth that might respond to holding the therapy and starting steroids, but likely with some long-term deficits in secretion. The second case series we're going to go over is Bruges and all and colleagues. This is a letter to the editor in response to Warner and colleagues. And so I think it's important to note that these two kind of came back to back, but they took very different approaches to treatment. And so everything was very similar with this case series in terms of patient characteristics. However, this center opted not to hold ICI for any of their patients, except if they progressed in their disease. And so they opted to really focus on basic oral care or supportive care, which resulted in very mild improvement. There was still mild improvement with focus on supportive care, but really the main improvement was seen after ICI therapy was held or discontinued. And in the few patients that steroids were started on, both of them showed significant improvement. So this letter to the editor was interesting because it advocated for continuing immune checkpoint inhibition, which is clearly our goal. We want to maximize ICI therapy for everyone we can and delaying steroids when we can, because this is not a life-threatening disorder with dry mouth. But they did acknowledge that there was not really significant improvement until they did hold ICI therapy and gave steroids in those few cases. And so what they kind of highlighted is that we just really don't know. And so their title even said optimal management still pending. Which leads us to our last case series, which was honestly I don't know if it's been peer reviewed yet. It's an abstract form, but I'm reporting it to you now just because it was technically the largest case series that we have of patients with Sicca syndrome. So I think it's important to see these. There are also a few differences in these patients. Most of them received combination immunotherapy versus the first series where it was mostly single agent PD-1 or PD-L1 inhibition. There were 4 patients still in this cohort that had pre-existing autoimmune disease. And all of the characteristics, again, very similar to the Warner and colleagues case series, that initial one that was published in The Oncologist. But I think there are some important things we can learn from this case series that are new. There were 10 patients that did note dry eyes. So, approaching a little bit like half of patients or a little bit under half of patients had dry eyes. What was very interesting, I think, is that 4 of the patients were completely asymptomatic, but on testing were shown to have reduced tear production. So it might be one of those cases where there is something kind of underlying and going on behind the scenes, but it's not as profound as what we see in the naturally occurring autoimmune disease setting in some patients. And so very interesting, I thought. And there are other IRAEs that there's something similar that we see that thyroiditis we don't see as profound of a hyperthyroid phase, things like that. One new thing as well from this study was that they noted a mean oral dryness score of 6.5 out of 10 that improved to 3.1 with either holding ICI or starting treatment. And so they did prove that there is a significant benefit from either withholding ICI therapy or treating the Sicca syndrome. Even though it's not full, it is partial improvement, and that's something worth noting. They did hold therapy in about 5 patients and started steroids in about half of the cohort. And even out of those 12, they still needed hydroxychloroquine later on. And so clearly something that can be a very challenging IRAE to treat. All right, this is the NCCN guideline set on dry mouth and Sicca syndrome. I'm not going to stare at this. I know the text is very small, so I'm just going to show you that this is what it looks like, and we're going to go on and highlight what the content is. These are the footnotes as well for that same section. With presentation, we've already been going over dry mouth. We've also been reviewing dry eyes, but what I want to note for you is that dry mouth might not be easily apparent from patients. You really have to dig into their history because I don't think that any patient really prioritizes or thinks that dry mouth is something that they should be really worried or concerned about. Um, but it certainly is, and it certainly is something that can be a long-term issue if we don't catch it early. So early identification is very important here. And so asking you about their dietary history, how things have changed, evaluating that oral mucosal cavity is really important. And so we have to get at the kind of maybe the changes that patients may or may not be fully aware of that they're making to their diet. Sometimes people do it kind of unconsciously, that they're more preferring soups, more preferring yogurt, other wet foods, bringing a water bottle with them when they used to not do so. Those types of things, because if we delay recognition, it can lead to severe and poor outcomes, such as loss of teeth. And so these are high stakes, and it's something that I have actually personally seen, that a patient lost teeth from this. Dry eyes, it could manifest as just difficulty with focusing. I've had a patient that had Sika syndrome and could not focus on her screen for longer durations of time. She was doing a master's program and had a real difficulty with her endurance when focusing on her screen. And so she needed to use a lot more eye drops. Things like that might be behaviors you see from patients. So assessing patients, really, we're trying to get at those underlying causes, right, and appropriate workup. And some of this might be more valuable than others. I think medications are very important here. There are tons of medications that could cause dry mouth, and so we need to make sure that we're aware of those, aware of any, especially new ones that have been started that could have caused that dry mouth to initiate. And also just assessing general hydration status, whether or not patients are actually creating saliva and have salivary pooling, what the consistency of that saliva is. I've had a patient that had Sika syndrome so severe with the thickness of her saliva that if she laid down at night, that she would feel like she was choking. So she had to actually sleep in the reclined position until we had her more controlled and on treatment for that. Also looking at the dentition, right? Knowing that the salivary barrier, that protection is no longer there. It's very important to be aware of dental cavities and recession of gums there. I would argue that laboratory testing is probably less important, although it is in some patients positive. And really important to note here that the salivary gland biopsy is not required here for assessment. And again, most of those patients are not going to have the antibodies anyway. So with grading, it's primarily driven by saliva and the ability to eat. And so grade 1, dry or thick saliva only with minimal food restrictions. Grade 2 or 3, the need for copious fluids to clear mouth of dry food. Diet limited to soft, moist, or pureed foods, or unable to eat, with the need for oral lubricants. And I've also listed the CTCAE grading below for you. They're very similar. Also include the saliva rate of saliva production. All right. In terms of management, early detection and treatment is the key here. And so we want to maximize hydration by limiting caffeine intake to minimize diuresis. Salivary stimulants such as sugar-free drops and lozenges are very helpful as well. And this is the key one, topical measures. Water sips is the key intervention that can be made to really immediately improve the quality of life of somebody with Sika syndrome. They may not be aware that they really need to carry around a water bottle with them everywhere, but it's really essential for them to have that. Some patients also like to use saliva substitutes, although many of the products are not very palatable and can be nasty. But there are many different products, and they can try various different flavors of them, if you will, with toothpaste options, mouth rinses, or sprays. And dietary modifications really is just avoiding those things that could be abrasive or harmful or cause discomfort or damage to the mucosa while there's not that saliva production. So avoiding crunchy, spicy, acidic, hot food drink. And then with grade 2 or 3 Sika syndrome, all of the supportive care we just mentioned absolutely would still be applicable. It might be that to the point if somebody's really not able to consume or swallow anything that we might have to admit them, although I have not been in that situation yet. And then there are the other interventions. So prednisone would be one intervention that could be done. These are not listed in order of what order you should use them, by the way. I think that there could be good argument for, holding ICI therapy and not using steroids and preferring a systemic sialagogue instead of a steroid first. And there's probably still ongoing debate about that. And so I think it's important to note that these are not in order. However, I think that prednisone is a reasonable option, especially because we have seen partial to more significant improvement, really limited to using steroids. And so just noting that that could be beneficial. And then escalating the dose, if it's effective, could result in additional benefit, and escalating the dose if it's initially not effective could be of benefit. So it's really kind of gauging, whether or not there's going to be that benefit, and escalating the dose really tells you a lot at that point. And if you've escalated the dose, we have a footnote in the guidelines. If you've escalated the dose and aren't seeing benefit, it's unlikely that you're going to see tremendous reversal of Sicca syndrome if you continue on for 2 weeks, beyond 2 weeks. And so we would taper after that. If you see improvement, hopefully we get that maximal improvement for 2 to 4 weeks and then taper thereafter. But you're not looking at initially needing a very, very high dose of Sicca syndrome. You might be able to get away with a lower dose. The systemic sialagogues are something that I don't think I used at all prior to understanding and recognizing Sicca syndrome. And these are those parasympathetic nervous system stimulants, the muscarinic agonists. They bind to M3 in the salivary glands, and they result in increased exocrine secretion. And so they have all of the side effects that you'd think of with the parasympathetic nervous system, and dizziness and sweating, nausea, diarrhea, runny nose, headache, all of those, blurred vision, polyuria. But they also increase that secretion, right? And so it might be worth those side effects, or maybe they are manageable for patients. So I think just noting that there is a therapeutic option for us to increase secretion is worth noting, but it might not be something that patients can tolerate. We usually start with pilocarpine first. I think they're both fairly similarly tolerated, but I think that pilocarpine is more easy to obtain from insurances. It's generically available, and in some cases could be better tolerated. We also, at this point, and you could do this, I think at maybe any point with Sicca syndrome, is refer to rheumatology and getting a rheumatologist involved. We have a fantastic rheumatologist, Dr. Bratton, who serves on the panel with me as well for NCCN, who's been fantastic with collaborating with our clinic and our team in managing these patients, because they do often require long-term management and care. Also, getting dental involved to evaluate any of those issues with poor dentition is really important. And in some centers, there's oral medicine specialists that are available, and we don't have those here, but I know of centers that do and have had tremendous benefit in getting their assistance. So revisiting our case, this is the female that had, during COVID-19, insisted on keeping a mask on, resulted in going to the dentist and being told that, hey, we're going to have to take out a whole bunch of your teeth. And I think clearly, hopefully from what you've heard so far, you would now be concerned about Sicca syndrome. And so in this case, I would say that this is an extremely severe case of Sicca syndrome. This is one that likely would indicate for steroids and a sialagogue, trying to hit it at both sides just because of how long it's been since this has been identified. And so again, that delayed identification is really important here. And, making sure that all the supportive care is in place, and talking to the patient about saliva substitutes and water sips and importance of hydration and all of those supportive care things go a long way, because those are what she's likely to have to rely on long term. And this is based on a real patient case that I was a part of here at Huntsman. The patient did lose multiple teeth, and my goal is to never let that happen again. So hopefully you will help that never happen in your site of practice as well. We're going to move on to oral mucosal IRAEs. We're delving into a little bit more of things that we understand a little bit, even less than Sicca syndrome, but we're going to go through them now. ICI-related mucositis. I think everyone probably on this call is familiar with mucositis and the inflammation of the mucosa, but probably more in the context of being chemotherapy-induced. But my message to you for you today is that chemotherapy is not the only cause of oral mucositis, and I have seen mucositis with ICI therapy alone. And so it does make these very difficult to classify, because I think that they're probably years from now we'll understand a little bit more of the interplay between them and understand more of the cause here in the etiology, but we're not there yet. And so some of this you might see some similarities and be like, why, this seems very similar. Yes, there are some similarities, and sometimes we don't know what's going on, and we're trying to just do our best to kind of get at the underlying cause and treat it appropriately. But once again, the incidence from that initial observational cohort was 5.4% for mucosal lesions. But in the meta-analysis that was done most recently, it was 2.7% stomatitis and 0.2% for severe oral mucosal immune-related adverse events. And so this is the entity we're talking about. I have witnessed it and treated it myself. This is the page. I would just orient you to how it's broken down. This is again laid out in exactly how you'd expect for NCCN guidelines with assessment, grading, and management. But one unique thing for the oral mucosa inflammation page is that we have a general section at the top that kind of applies for all those general supportive care management and referrals that apply to all of the grading. And so we have that at the top, and then in the traditional format for the grading below with management. Footnotes here, and then we go on to presentation. So this is, again, probably exactly what you would expect from presentation of normal mucositis with a patient with chemotherapy, the irritated gums or in their oropharynx as well, red or white lesions or ulcerations, inflammation of just the general gum area. But another one that you may not have seen before is lichen planus, and we're going to talk about that a little bit later, more kind of as its own entity, so I won't talk about it a whole bunch now, but keep that one in mind, that there is some overlap here in interplay, and we'll highlight that one on its own. With assessment, we want to completely assess the mucosal cavity, assess for any primary oral inflammatory disease that might have pre-existed, pain score or alimentation limitations. And so any of those baseline, just understanding how bad is the pain right now? How bad is it that can the patient swallow? How, getting the severity of it down pat is what we need to grade it appropriately. We may consider a mucosal biopsy because often we don't understand what's going on in oral mucositis, especially with ICI therapy. Looking for any skin blistering that would signal any other skin disorder. And then finally, a fungal and viral swab of the oral erosions. This is one of the more common causes actually that we could see. Ruling out any candidiasis, ruling out any HSV infection is really important because those can present in similar manners. And then looking at various different combination regimens and whether or not a chemotherapy agent actually is at play here that could be causing it in the more traditional sense. With grading, this is, again, somewhat what you would expect and somewhat not. We've, in NCCN, have taken more of the approach of with food restrictions, grading by food restrictions. So with grade 1 being some food restrictions, grade 2 being softer pureed foods only, and grade 3 or 4 being unable to eat. Whereas you can see the CTCAE criteria below focus more on the severity of symptoms, which I think is also indicated by the ability to eat or not, and pain or ulceration. And so you can see the stratification here. In terms of management, certainly dietary management is always going to be the same kind of thought process as we were talking about with Sicca syndrome here, avoiding those things that would insult the membrane or the tissue. Maintaining good oral hygiene because of that gum recession risk and the inflammation that's going on there. It's very important to try to keep away any infectious risks, potentially considering chlorhexidine rinses. And then referring, I think, especially if there's a suspicion of this being ICI-related mucositis, referring to appropriate dermatologist or oral medicine specialist, potentially a dentist as well for evaluation of good dentition, and an ENT specialist. I think any of them would be appropriate for this. With management, we often will add acid suppression, at least with mild cases of mucositis, because potentially there is some contributing factor that we could mitigate or reduce with PPIs or an H2 blocker. and consider also a high potency topical steroid. And this is where it gets into some realms where you may not have used these in this fashion or in this way. But actually, using a dexamethasone rinse or solution as a mouthwash almost. And so it's at this point we would really be looking at a patient that has mild mucositis being given a script for dexamethasone mouthwash to rinse and spit 4 times a day. Try to get that local anti-inflammatory effect going, and then considering more potent steroids later. Topical anesthetics could also be considered just for comfort level. So we'd be talking about magic mouthwash with the mix with lidocaine and such. And so those are we're more comfortable with, right? With mucositis is often what we send for patients with mucositis, but those same kind of things can benefit patients in this setting as well. With grade 2 or moderate oral mucositis, we would then hold the immunotherapy agent at this point, and then consider a little bit more high potency topical steroids. And so what are we talking about at this point? Well, there are other options we can be using for steroids beyond even just the dexamethasone rinse that might stick around a little bit longer, might bind a little bit longer to the oral tissue there. Preferably a gel would be best. There are fluocinolone formulations that are gels that are very high potency topical steroids. Sometimes those are hard to access or get. And so in certain situations, there have been opportunities to compound a steroid cream or gel. And then you could also consider, if you're desperate, which I have done before, using a non-oral kind of formulation, either a cream or ointment in the oral mucosa. And that one is I probably comfort level for any of us is not high for that, but I have seen success with that. Tacrolimus 0.1% ointment is another option, or another compounded solution for lips. You may combine that with topical steroids intraorally. So both of those immunosuppressants could be helpful at this point. And then also finally considering high-dose systemic steroids for this, because you'll note we're dealing with grade 2 moderate mucositis. It is something that can be very impactful and cause weight loss and other symptoms very quickly if not dealt with. And to this point, you'd also want to be getting an oral biopsy to see what really is going on. Grade 3 or 4, this is where we would also be still holding the ICI, but probably admitting a patient and still using the topicals, but probably even higher doses of steroids and getting that biopsy done. So I have another case for you. MB is a 24-year-old female with metastatic melanoma who has received cycle 2 of Niv-Ipi, and this has been on hold for the last 6 months due to immune-mediated hepatitis, which she just recently finished a steroid taper for. She comes into the clinic with complaints of sores on her tongue and cracking in the corners of her mouth for 1 week. She's sent nystatin and magic mouthwash, which helped initially, but did not resolve the sores. However, she's since noted worsening in her gums and tongue, which have now become sore and red. She's able to eat and drink with some discomfort. The oncologist would like to proceed with cycle 3 of nivolumab. So which disorders or IRAEs should we be considered in the differential for MB? So I want you to think about this. What would you be thinking through based on that assessment map that we kind of laid out? And I think in my mind, I would be thinking of oral herpes, oral candidiasis, with that extensive steroid history that she had. Those are very high risk, right? With steroids having just finished. And so, but it also could be mucositis. It could also be lichen planus, which is what we'll talk about in a moment. So this patient does have a herpes swab done, and she's continued on nivolumab. She comes back after having been seen by ENT and started on fluconazole for 1 week for presumed oral candidiasis, which improves the situation somewhat. But after stopping the fluconazole, her symptoms worsen per her report. Her PCP states she must need a longer course of fluconazole, so she resumes the fluconazole at a higher dose, and her symptoms don't improve this time. A month passes, and her PCP again starts an antifungal with itraconazole for presumed worsening oral thrush. Her symptoms briefly improve, then worsen again. Her mouth's now painful with eating, and her gums bleed with brushing teeth. She's lost almost 10 pounds in the last 2 months. Her mouth sores have worsened on the inside of her lips and the sides of her tongue, and a fungal swab is negative. So, what would you think? Try to be honest with yourself. What would you think needs to be done now? What would you do based on the management stratification in NCCN? I would argue that this patient's probably beyond grade 1, probably not grade 3 or 4 yet, but I would say that probably solidly grade 2 grading. And so I think that holding ICI therapy is absolutely the most appropriate thing at this point. Going for one of those high or very high potency topical steroids, either dexamethasone rinse or a topical like fluocinolone or clobetasol. We could also consider tacrolimus because I think, especially if there's any involvement of the lips, oral or systemic steroids might be considered, but I think that, since there has not been any attempt to use topicals, I would probably do that first here, and then getting that biopsy done. So with part 3 of the case, the decision was made to give topical clobetasol to her oral mucosa on a Wednesday, and by Friday, her white spots had completely disappeared. The redness and pain had improved substantially. She tapered off the clobetasol over the next month with complete resolution of the mouth sores, and she's presumed to have initially had oral candidiasis superimposed with immune-mediated mucositis and or oral immune-mediated lichen planus. With lichen planus, this is where the overlap comes in, and this is something that you may not have ever seen or heard of before, but this is an inflammatory condition of the skin or the mucous membranes. And lichen is actually something that's found growing on trees, and that's where it got its name. It's found in the garden or forest, and the reason why this is even named this is because of how it appears. It's like almost like a fungus or an algae, kind of like a flat-topped organism type look to it. And so one thing that we note with patients who experience this is that there's kind of these striae or kind of branched striae that are white streaks in the oral mucosa, and you can see them kind of in the photos I have here, and erosions in that area as well. So the Wickham striae are the hallmark sign of lichen planus here. And this is a T-cell mediated attack of the basement zone membrane of the mucosa here. And so there's really not any way for us to differentiate between lichenoid mucositis, which happens, and lichenoid lesions, which also happen. And so this has just been described as lichen planus. And so this is the appearance of this disorder, but there are very similar aspects of this that match mucositis. So here is the stratification, the guideline page for lichen planus. This includes also skin-involved lichen planus and lichenoid diseases. And so the grading doesn't match perfectly because it also includes those others. And so I think pain, if you note that pain is one of the primary symptoms of oral lichen planus, I've included here for you the grading for oral mucositis, which I think most closely aligns with what we're trying to get at here. Management of oral lichen planus is very similar to what you see with mucositis. A little bit less of a preference for systemic steroids, but certainly getting high potency steroids started early, getting that as an option. Tacrolimus can also be used for these patients, is important to note. And so oral antihistamines may also be useful in this case. And then if we don't get response with high potency topical steroids or systemic steroids for grade 2, we treat as severe. And with severe, we do start looking at a little bit of the lower dose, high range of steroid dosing here with lichen planus, considering a referral to dermatology, who are the best suited to treat lichen planus, and possibly considering other steroid-sparing immunosuppressants if we don't have a response at that point. And the final one we'll look at today is oral dysesthesia. And this is something that's a small section below Sicca syndrome in the guidelines I've highlighted here with the same footnotes for both sections. And this is really, what some refer to as burning mouth syndrome. And this is one that's probably the least understood of all the ones we're talking about today, but it is something that is a burning mouth sensation. It's a persistent altering or alteration to oral sensation in the mouth. And so this is something that there have been anecdotal reports about. I am not sure, to be completely honest and transparent, that this is in and of itself an oral IRAE, or if it's a secondary effect of another immune process that's being noted, whether or not lichen planus or something else. But usually with this disorder, oral dysesthesia, there is no visible evidence of any other issue that's occurred or happened. And so for assessment, it's a much shorter assessment section here, assessing the location and the character of the pain, really trying to best understand what this pain is and what it behaves like, ruling out any other sources of the pain, assessing how severe it is, and the thickness of the saliva to try to get at maybe Sicca syndrome or some other disorder is involved here. The grading all has to do with pain, and so I have it listed for you here in the grading that you would expect: mild discomfort extending all the way to disabling pain. And for treatment, really, it's focused on, again, those dietary modifications, topical measures, using some oral anesthetics in this case with more mild pain, but then extending into the grade 2-3 range, adding in that kind of neuropathic pain treatment of gabapentin. And that's the extent of that section so far. So last thing I'll leave you with is a note on patient education of immunotherapy-associated oral toxicities. We do have a really interesting resource that I've enjoyed reading through and helped contribute to, just in terms of how we frame these types of immune-related adverse events for patients. And it's a document that can be downloaded for free on NCCN's webpage. And there was a new section added when the Sicca syndrome and other oral toxicities were added to the guidelines. We added now a skin and mouth section that has been added. So I think it's really good to go there if patients aren't really understanding, or if you want to provide something for them to read and understand more about, they can access that for free. But the most important thing, I think, to communicate and educating patients about these things is to just make sure they understand that there is a possibility of oral toxicity and all of the long-term risks that could occur. In my mind, when I'm processing Sicca syndrome, I view it almost akin more to an endocrine type IRAE than a non-endocrine type IRAE. And I know it's not endocrine in a sense, it's a rheumatologic disorder. However, it behaves more similarly to the endocrine IRAEs in the sense that there is permanent glandular damage that results in long-term effect and poor exocrine function that is similar to what we see with other endocrine disorders like thyroiditis and hypophysitis in that setting. Key takeaways for you today. I hope you have an improved recognition of the possibility of oral toxicities from ICI therapy, and hopefully you'll use that to rapidly identify and manage your cases if you do see this in your site of practice. Sicca syndrome is the most common oral toxicity that we know of right now from ICI therapy. It is something that can significantly impact quality of life, so it's very important to identify it quickly. We know that the best and most effective ways to manage this are to hold ICI therapy, to give a sialagogue and low-dose steroid therapy. But the best management for this is still unclear. And so hopefully we'll understand a little bit more about this and the best way to go about maximizing ICI therapy in future years. This is something that would require long-term management. And so we refer patients to rheumatology frequently. And so keep that in mind, that you get that rheumatology referral in early so patients get appropriate care when needed. Chemotherapy is not the only cause of oral mucositis. Keep that in mind. Don't assume it's the chemo, especially if a patient's mucositis doesn't improve. They might need steroid therapy to reverse that. ICIs can cause those painful oral lesions and inflammation, but oral lichen planus is another kind of overlapping disorder that might coexist with oral mucositis and looks kind of in that striae fashion with Wickham striae. And so when you see that and you see those branching in a patient's tongue or the side of their mouth, and it's accompanied by severe pain, it's probably something that you're dealing with is lichen planus. And so keep that in mind as you see patients and hear them describe pain. Don't just ignore it. These management strategies are evolving. I'm sure that this will change in a few years, but I hope to have given you some baseline understanding today. Yeah, so I'll just read the first question. I think it's a really good one. But does radiation make the Sicca syndrome worse? And do topical steroids have a place in treatment? I think absolutely. I think that in some of the cases that I've been involved with, the patients have had a level of radiation-induced dry mouth at baseline that for whatever reason, became substantially worse. And so there was initially a question in, I think, one or two of the patients we've treated that, what is this due to? Why is it worsening? Because they had had radiation distantly. It wasn't something that had been recent. And so I think it absolutely predisposes them at least to being affected more severely. I do wonder if there are patients that are being impacted by this that are not symptomatic in the sense that we would think, and they're just going under the radar and not saying anything, or not being what we would consider manifesting as symptomatic. But in those patients where they don't have as high of a reserve, or that they've had baseline salivary gland damage, that they are manifesting more readily because of that. And so I think that that's a great question. I think absolutely topical steroids do have a place in treatment. With the discussion we had earlier on, and we've used topical clobetasol and other gels, whatever really we can get our hands on, because usually by the time we need those, patients are suffering pretty badly. And sometimes we run into insurance issues and things like that, which are not great, but absolutely trying to use topicals when possible, and maybe even continuing eyesight therapy while using a topical. What about triamcinolone paste for treatment? I have not used triamcinolone paste. I think one argument against that would be that just because of the potency of the triamcinolone being a moderate potency topical corticosteroid, that it may not work. But I think that's a super reasonable option, especially if you're trying to taper a patient, or you've had issues with using the higher potency topical corticosteroids. Because what we have found is that when we've used topical clobetasol, occasionally it's very important to limit it as much as possible, because you're playing with fire. With a very high potency topical steroid in the oral mucosa, you risk gum recession and other ways. Even though you're reducing that inflammation, you're affecting that tissue in that way. And so I think that's a great point. I'm going to have to put some thought to that, using a moderate potency paste for that. Third question: how would the topical clobetasol be prescribed or used inside the mouth, swish and spit? What dose would be used? Yeah, so again, I think understanding the true incidence of this, I don't really understand or appreciate, but we've had a handful of cases. So this is my anecdotal understanding with a handful of cases, and then trying to understand in the breadth of the experience that others have had, with our case series being limited to those 60 some patients that we talked about earlier. I only have a few times where we've actually used topical clobetasol in the mouth. I think that what we've done is exactly what you're suggesting, is applying to the most problematic lesions, having the patient kind of not swallow for a minute to 2 minutes, and then spit that out and rinse afterward, has been our process. The clobetasol is just the normal 0.05% strength that we've used previously. I hope that helps. That's my experience. I would not claim that be the only answer, and I think that hopefully we'll understand more in the future. One more question. So this is a great question. Are you seeing any cases extend into lower GI structures that warrant other formulations of steroids? This person is thinking of GVHD locations as a comparator from hematopoietic stem cell transplant. Yes, and I think that's something to note here, is that we're kind of focusing on the upper mucosa. There clearly are IRAEs that are better recognized that are affecting the lower mucosa. And so I'm thinking of esophagitis, gastritis, colitis even. And so those, I think, are better recognized. So you could argue maybe that esophagitis and gastritis are a little bit less well recognized as colitis, but certainly those have more attention already. Yes, absolutely different treatment. We prefer more so the systemic steroids for those cases. It's just a little bit more challenging to get topicals to be effective in those areas. There are limited examples of where, like for microscopic colitis, we can get away potentially with a topical steroid. But I think apart from that, there are a few examples of us being successful with other formulations of steroids. So do IRAE oral toxicities tend to occur alone or simultaneously with other IRAEs? this is a point that I meant to make earlier, and I failed to do that. So I love that whoever you are asked this. But one of the risk factors that's clear from that, I believe the third case series, is that the majority of patients with Sika syndrome also have another IRAE, which is not always the case. You don't always see that there's an IRAE that seems to always correlate or coexist. Maybe there are a few examples with myositis and myocarditis, but with Sika syndrome, it does seem that if you have an IRAE at baseline, it does predispose you to a higher risk of Sika syndrome, as well as having pre-existing autoimmune disease. It does seem to potentially be another risk factor. So if there were any risk factors for Sika syndrome, it's probably those two things. I think that's it for questions. It's been a pleasure to be with you, and I hope you've learned something. And I really appreciate your time and attention today.